advantage of offering it on this day, which of course only occurs every 4 years. We thank you for joining us. We thank you for your support of the Medical Society and all that we do. And we look forward to continuing to serve you in 2024. And we have a number of things that we're going to mention that are coming up and more that are planned. So what I would like to do is first introduce Jack DeGioia, who is with Medex Waste. Medex Waste is one of our newest partners with the Medical Society. And because of its relevance to today's conversation, we wanted Jack to be able to share a little information about his company with you. Jack?
Thank you, Susan. Thank you, everyone, for letting me talk for a couple of minutes here today. So my name is Jack. I'm the owner of Medex Waste. We're all things medical waste disposal and sharps disposal. We also do some side things like shredding and hard drive shredding as well with our sister company. But our bread and butter is that medical waste and sharps container disposal. We service all of DC, Maryland, and Virginia. There's actually a couple clients, I think, in here that we service. Dr. Mintz's office, we do. But yeah, if you guys are in need of anything, if you guys are looking to get out of contracts, I know the larger companies can lock you into those 1 to 3 year contracts and tie you into those fees and energy fees that you'll see on your invoices. With us, there's no contracts, no extra fees involved. It's all flat rate pricing. And we're locally owned and operated right here in Montgomery County, based out of Rockville. So if you need any help with that, all of my information is right there. Please feel free to call or email me at any point. Thank you.
Thank you, Jack. And just a word about our partners. All of our partners have been vetted and they come to us through testimonials from practices that are already using them. And so we really encourage you when you're making a purchase decision to consider our partners so that they too can give you the benefits that other medical society members are already realizing. So thank you, Jack. One of the other things that Jack's company offers is a platform for regulatory compliance. And we will be talking about that a little bit more today after the presentation by our OSHA speakers. So now I want to remind you just of a couple of things that are coming up in the Medical Society. We are going to have a Lunch and Learn webinar on March the 18th, which is about fraud and security. This will be a longer format webinar offered by Sandy Spring Bank, and it's going to be offered at 1 p.m. that day. So we encourage you to note that. I mean, we all know that fraud and security issues are getting to be greater concerns for all businesses, especially medical practices. And so we would encourage you to attend that. We also have had very successful collegiality dinners. If you have a new physician on your staff in your practice who needs to build a referral network, we really encourage those physicians to join us for collegiality dinners. It's going to either be April 10th or 11th. We're working out the details right now, and more information about that will be coming soon. Also, I wanted to mention to you that our annual meeting where we install our new officers and the reception is going to be on Wednesday, May 8th. It is at the Marriott on Pooks Hill Road in Bethesda. We have an exhibit hall from 5 p.m. to 7 p.m. It will be open to members. It's a little different in that we are also raising funds for the National Capital Physicians Foundation to support our physician well-being efforts. So encourage you to also put that on your calendars, encourage your physician members to come, and there'll be more about that to follow too. So today, the reason that you're all here is that we want to continue to offer OSHA compliance programming and using our most informed speakers that are from Maryland Occupational Safety and Health, which is referred to as MOSH. Today, we have Erin Stanton, who is an industrial hygienist with us. And then also Cristina Campbell Harris, who is a supervisor in that area, will be available through the program. She's not our primary speaker, but she will be available to answer questions at the end. So today, our speaker, Erin, is going to talk about basically MOSH and OSHA, an overview about that, a lot about bloodborne pathogens, hazard communications. We've all learned a lot about the use of PPE in the last several years, but again, this is a critical part of staying compliant with OSHA regulations, and then other OSHA and MOSH regulations that affect medical practices. So again, we thank you for being with us. What we're going to do now is have Erin speak. After Erin speaks, we will take Q&A about her presentation. And then we will talk a little further about the platform that I was referencing earlier to see whether or not there is value to offering that to our medical practices. So that is how we're going to handle the presentation. I encourage you to remain muted during this conversation. You can have camera on or off, whichever is your preference, but please do not unmute until we get to the end for Q&A. So without further ado, I'm going to introduce Erin. Thank you for joining us, Erin. We really appreciate you sharing your expertise and insights with us today. We look forward to your presentation. Thank you.
Thank you, Susan. I'm going to share my slides now. And yeah, thank you everybody for coming out today. We are going to do a bit of an overview of OSHA regulations, things that apply to you as medical professionals. So thank you for introducing me, Susan. My name is Erin Stanton. I've been with OSHA or MOSH for about 1.5 years now. And that's my email, my desk number right there. If you have any questions, we will address that at the end. So today's objectives are we're going to identify OSHA standards that are applicable in the medical settings that you work in and describe the employer requirements for complying with bloodborne pathogens and hazard communication standards. I understand that in your medical society, this is just one of a plethora of things that you do to keep informed about health and safety in the workplace. And so I'm happy to provide you with a bit of an overview and some updates today. So we'll start with the applicable OSHA standards for medical professionals. We'll talk mostly about bloodborne pathogens today, which comes out of Title 29 of the Code of Federal Regulations, 1910, which refers to general industry. And the number is 1030. We'll talk a little bit about hazard communication, personal protective equipment, access to records, and notably a few other standards that apply to medical practices would be there's expanded health standards for things like formaldehyde, we're dealing with preservation, ethylene oxide used for sterilization in medical practices, as well as things like sanitation, first aid, exit routes. All of these things are standards that OSHA has that would apply to medical practices. So we'll start today by talking about bloodborne pathogens. A little bit of an introduction. There are approximately 5.6 million workers in healthcare and other facilities are at risk of exposure to bloodborne pathogens. Primarily, when we talk about bloodborne pathogens, we'll be referring to HIV, hepatitis B, and also hepatitis C. OSHA's bloodborne pathogen standard prescribes safeguards to protect workers against the health hazards from exposure to blood and other potentially infectious materials. And so let's define other potentially infectious materials. So that includes semen, vaginal secretions, cerebrospinal fluid, synovial fluid, pleural fluid, pericardial fluid, peritoneal fluid, and amniotic fluid. It's important when we're talking about the bloodborne pathogen standard to understand which bodily fluids can transmit these diseases and which can't. So what is not considered OPUM are tears, urine, vomit, sputum, feces, sweat, and outside of dental procedures, saliva is not considered OPUM. I think we can all understand that in dental procedures, saliva has the possibility to carry blood, so we handle that differently. And like I said, the diseases that these bloodborne pathogens can cause are hepatitis B, hepatitis C, and HIV and AIDS. Some notable things about hepatitis B are that it is vaccine preventable, and we'll get into that with the standard later on. And it can have no symptoms at first, and when it does carry symptoms, those are usually fatigue, poor appetite, stomach pain, nausea, sort of general sickness, viral symptoms, as well as jaundice, because this is a disease of the liver. So who is covered by the bloodborne pathogen standard? All employees who could be reasonably anticipated as the result of performing their job duties to contact blood and other potentially infectious materials. So it is the employer's responsibility to determine which job classification or specific tasks and procedures involve this occupational exposure that is reasonably anticipated. So the term reasonably anticipated means there's a potential contact or actual contact with blood or OPUM. And if it's happened once, it's reasonably anticipated. And if it hasn't happened yet, but there's a possibility that it could happen, we consider that reasonably anticipated. So who is most at risk? Some examples I have are physicians, nurses, which are, I'm guessing that's you guys, and emergency room personnel, orderlies, housekeeping personnel, laundry workers, people who are taking maintenance or performing maintenance, taking care of others, medical examiners, morticians, as well as firefighters, paramedics, and now let's talk about how does that exposure occur. So most commonly, a potential exposure could occur through needle sticks, but it can also occur in other ways, such as cuts from contaminated sharps. You cut yourself and with a piece of material that is contaminated, there's that potential for that to have contact with your blood, as well as any contact with the mucous membranes has the potential to transmit these diseases. So the bloodborne pathogen standard has specific requirements that are outlined here. These requirements include a written exposure control plan, implementation of engineering and work practice controls, providing personal protective equipment, implementing a housekeeping procedure, offering the hepatitis B vaccine to those who are potentially exposed, providing procedures for post-exposure evaluation and follow-up, as well as training before starting the job, and record keeping for certain records, such as hepatitis B vaccine records or declination vaccine records, as well as other things. So when we're talking about the different controls that we use in the workplace to keep our workers safe, there's a natural hierarchy of controls. So we start with engineering controls, and if that is not possible, not feasible, then we looked at work practice controls. And then if workers require more protection after that, then we look at personal protective equipment. So engineering controls reduce employee exposure by either removing the hazard or isolating the worker. Some examples of this, as I'm sure you see in your practice every day, are sharps disposal containers, self-sheathing needles, as well as safer medical devices, which are inherently engineered. And we'll talk a little bit more about these needleless systems and sharps, engineered sharps, a little bit later. So, or right now, as well as a bit later. So the needleless systems are a device that does not use needles, but still gets the medical job done. If we're looking at administrating fluids or medication. And if we need to use needles to get the job done, then we have sharps with engineered sharps injury protections, such as retractability, blunting features, and I'd like to go over some of those with you today. So we're going to look at some examples of engineered sharps. I have some pictures. You can see here that there's a picture of a sheath and the sliding blade guards. And we're going to talk about options with scalpels as well. So here we have a hypodermic syringe with a retractable technology feature. These at this point are widely available and used. and it provides for retraction of the needle after injection to provide protection for the individual who is supplying that medical care. Additionally, you can find on the market add-on features. We might refer to these as sheaths, which, as you can see, are added onto the sharp and can flip down to provide protection, making it virtually impossible to stab yourself with that sharp. Additionally, when we're looking at phlebotomy or more sophisticated sharps here, there's something called self-blunting sharps. And what this does is after use, but while still in the vein of the person that you're administering care on, the device is activated, causing the blunt end to protrude forward and cover that sharp end, which provides protection to the phlebotomist or the medical professional at the most critical time, which is while they're providing that care. So that protection, that blunting feature happens actually before you remove it from the person's vein. So that provides lots of protection for that phlebotomist. And additionally, when we're talking for phlebotomy, we're also dealing with butterfly needles. Some butterfly needles have a spring mechanism that retracts the needle back into the device to make it virtually impossible for that sharp to come in contact after it's used. And additionally, some of these engineered protections are more active, which requires the user to do something to activate that protective mechanism, and some are passive. For example, this phlebotomy needle is a passive shielding safety feature. If you're going to use this needle, it has passive protections that does not require the user to do anything specific. When we're talking about sharps, oftentimes we're dealing with sharps when we're dealing with diabetic individuals who often use lancets to monitor their blood glucose. And we have retractable lancets with safety features. So after you use it, then the sharp is retracted, providing protection if somebody else were to be providing diabetic care on another individual. Additionally, we have disposable scalpels with safety features that retract and protract, and they're single use. And they have that safety feature, that retractability to provide protection. So how do sharps injuries actually occur? According to the CDC, 48% of the time, it's during use of the item, as you can see on this graph. 30% is after the use and before disposal. So that right there, that we can see that almost exactly half is during use of the item. So that's important to keep in mind when we're engineering these products and providing protection. It's also important to note that workers may incur injuries from improper procedures, such as passing sharps hand to hand between team members, placing sharps in a regular trash can, or failing to use a safer device. So it's important to consider many factors when we're choosing what safety devices to use. And we have a list of questions here, things to consider. Does the product require use of the safety feature? Is a safety feature an integral part of the device? Does safety feature interfere with vision? Is it going to cause any other problems or cause any modifications that may be needed in the process? And I'll let you read the rest of those questions here. These are things that we think about when we're choosing what devices would be most appropriate. A few more questions. Does the safety feature require the user's hand to remain behind the needle at all times? Does the product cause harm or discomfort to the patient? Is there an audible/visible sign of activation? We want to be thinking about how the safety feature is going to look in real time. So NIOSH, as I'm sure you all know, the Institute of Occupational Safety and Health, separate from OSHA, what they have done is issued guidelines for selecting and evaluating needle devices with safety features. They've separated it into five considerations, and I've provided you here with just the beginnings of the sentences that sort of convey what those guidelines are. So we're going to form a multidisciplinary team that includes workers, identify priorities based on assessments. When selecting a safer device, identify its intended scope of use, conduct a product evaluation, and monitor the use of a new device after implementation. So we talked a bit about engineering controls. Now we're going to talk about work practice controls. So work practice controls are controls that reduce the likelihood of exposure by altering the manner in which a task is performed. And if we can't we can't engineer out the hazard or isolate the worker, then we can implement work practice controls. So I'm sure you're all aware, but OSHA defines universal precautions, and it's an approach to infection control where all human blood and certain human body fluids are treated as if known to be infectious for HIV, HPV, HCV. So we're assuming that all of these bodily fluids are do have these pathogens present. So we have some, I apologize that the lighting is going out. So we have some terms that I'd like to define for you. So we know what universal precautions are. And we also have standard precautions. So standard precautions are further protective than the universal. They protect healthcare workers not only from pathogens in human blood and other body fluids, but also pathogens present in body fluids to which universal precautions do not apply. So standard precautions would include things like hand hygiene. And standard precautions are observed by most healthcare facilities because they are more protective than the universal precautions. And as well as body substance isolation. So that is body substance isolation emphasizes avoiding contact with all moist and potentially infectious body substances, except sweat, even if blood is not present. And then, so these approaches to infection control where all body fluids are treated as infectious. Another term I wanted to define for you was transmission-based precautions. And that term is for contact, droplet, and airborne transmissible diseases. So that's considered an augmented of the standard precautions. So it's further protective where standard precautions may not be fully protective. So work practice controls, of course, hand washing, and it must be readily accessible. We want to keep in mind if something were to happen and somebody needed to wash their hands right away, keep in mind the placement of doors, the way that worker might have to walk. We want to keep these things in mind. Of course, no eating, drinking, smoking, or applying cosmetics in areas with exposure. No more mouth pipetting. We don't do things like that anymore. And so any processes like that might involve potential direct exposure with the human body, we're not going to do that anymore. And recapping of needles is a bit tricky. This is permitted by OSHA under very limited circumstances when there is no alternative to the process where the needle must be recapped. So now let's discuss personal protective equipment. As you all know, specialized clothing or equipment worn by an employee for protection against a hazard. You can see I included a list here of what OSHA considers appropriate personal protective equipment for medical personnel who may be exposed to bloodborne pathogens. And that picture on the right may be what some of you look like sometimes on some work days. So when we're talking about personal protective equipment, the employer is responsible for providing that equipment at no cost, requiring its use where it's necessary to protect the health of the employee, ensuring that there's a proper fit we need to keep in mind the differences between individuals and ensure that the personal protective equipment is suited for their specific body. And the employer is responsible for cleaning, laundering, repair, replacement, disposal of the protective equipment. If it's not disposable, then lab coats, uniforms, and the like used as PPE must be laundered by the employer and not sent home with the employee for cleaning. It is important to note that this includes scrubs. So employees need to be trained to remove contaminated scrubs properly as to avoid contact with their skin of potentially infectious material. And of course must be removed upon contamination and prior to leaving an area. So, like I said, these are examples of things that would most likely apply to bloodborne pathogens. Lab coats may be necessary sometimes. If there's potential for splatter, they may not be necessary in other times. Obviously, it's important to consider the nature of the work and those potential hazards and do that assessment. Gloves, we're going to be wearing gloves most of the time. They must provide multiple sizes and non-latex options for those who have latex allergies. And hand washing must occur as soon as feasible after glove removal. That's why I mentioned we want to be considerate of where the sink is, where the facilities are in relation to those workers who are getting their job done. And alcohol hand rubs are okay only when a sink is not available or if there's no contact with blood or open. Housekeeping. So housekeeping is very important when we're talking about bloodborne pathogens. So the standard requires a written housekeeping procedure. So we're going to see a written schedule. And in that schedule, we'll be outlining how we're going to be using our appropriate cleaning and decon chemicals. And we're going to outline the procedures for regulated waste and for contaminated laundry. So we'll discuss that a bit now. So like I said, they must develop a written schedule for cleaning and decontamination at the work site based on the location within the facility, the type of surface to be cleaned, the type of soil present, and tasks or procedures being performed. So I have an update, a very recent update regarding this. And when we're doing what this guy's doing in this picture, we from now on are going to be looking at EPA's new list. So previously the EPA had listed in list C and D which registered disinfectants are appropriate to use when we're considering bloodborne pathogens. So the EPA has now published list S. And when you go to list S, you will see which products the EPA has listed as effective sterilants and tuberculicides, effective against HIV and HBV. And a fresh bleach solution of a ratio of 1 to 10 of up to 1 to 100 is appropriate as use to be effective against these pathogens. And it's certainly important to keep in mind the contact time that is necessary for these chemicals on the surface before we reach that point where it's doing what we want it to do. All right. So regulated waste is waste per OSHA is waste contaminated with blood or opium that it's saturated, dripping, or the material is able to release blood or opium in wet or dry form. So these things that fall under regulated waste must be placed in closable, leak-proof containers built to contain all of the contents if it were to leak. And they must be appropriately labeled and or color-coded. And when we're talking about sharps containers for regulated waste, they must be closable, puncture resistant, leak-proof on the sides and the bottom, labeled, easily accessible, which is a big one, and replaced routinely. Best practices for sharps containers is within arm's reach and emptied once it reaches about 3/4 full. So you can see here this woman has at about eye level of 57 inches when you're standing, 52 to 56, 7. And when seated, 38 to 42 inches. And these have been, these will comfortably accommodate 95% of all adult workers, according to NIOSH, with these measurements. And of course, sharps only, no other waste or debris, and final closure should be resistant to tampering. Some common mistakes that we see with sharps containers: improper placement, too far away, too high, behind a door, under a sink, not practical, overfilling, infrequent replacement, or it's too small for the work that's being done, or we're seeing disposal of other items besides sharps in these containers. All right, reusable sharps. So these shall not be stored or processed in a manner that requires employees to reach by hand into containers. Instead, we want to use forceps, strainer buckets, things that do not require an employee to reach into a bucket or a bin. All right, so contaminated laundry is that which has been soiled with blood or opium or may contain sharps. So per the standard, laundry must be handled as little as possible and with use of PPE. It must be bagged or containerized at the location where used and not sorted or rinsed at the location where used. Must be placed and transported in labeled or color-coded containers. Labels, the biohazard warning label, are required on containers of regulated waste, refrigerators, and freezers containing blood or opium, as well as other containers used to store, transport, ship blood or opium. And this biohazard label must be predominantly fluorescent orange or orange red with lettering and symbols in a contrasting color. There are a few exceptions to labeling. These include specimen or laundry containers, if universal precautions are used. So for example, we're going to use universal precautions such that all laundry is placed in green bags. If all employees are trained to understand that we need to use universal precautions and anything with a green bag has potential exposure to blood or opium, then they are exempt from labeling if that is done. Exceptions also include products for transfusion, container in labeled containers, decontaminated waste, and red bags and containers are substitutable for labels. As you saw in that picture earlier, the red bag denotes that. All right. The hepatitis B vaccine. So like I said, hepatitis B is a vaccine preventable disease. The employer is responsible for making available free of charge at a reasonable time and place the vaccine within 10 working days of initial assignment. It must be provided even if the employee initially declines, but later decides to accept. And those employees that do decline must sign a declination form. And of course, the vaccination must be performed by a licensed healthcare professional. Post-exposure. What to do if an exposure occurs. As soon as possible, we're going to wash the exposed area with soap and water. We're going to flush splashes to nose, mouth, or skin. Irrigate the eyes with water or saline if we have an eye wash station. Report the exposure to the employer and direct the worker to a healthcare professional to receive an evaluation and treatment if necessary. For a follow-up of post-exposure, we're going to document the routes of exposure and how that exposure occurred. we're going to record the injuries from the sharps in the sharps log if the employer is required to maintain one. And the requirement to establish and maintain a sharps injury log applies to any employer who is required to maintain regular illness and injury logs. And we're going to obtain consent from the source individual and the exposed employee and test the blood as soon as possible after the exposure incident. Of course, we need to receive consent from this for this. And if the employee consents to baseline blood collection but does not give consent at that time for the HV serologic testing, then the sample must be preserved for at least 90 days. Additionally, the employer will provide risk counseling and offer post-exposure protective treatment in accordance, if medically indicated, in accordance with the public health service. So they're going to make available counseling and offer these post-exposure protective treatment for disease. Additionally, provide written opinion of findings to the employer and copy that to the exposed employee within 15 days of the evaluation. Training. So, training must be provided at the time of initial assignment to a job with occupational exposure and at least annually thereafter. It must be provided at no cost to the employees during working hours. And additional training needed when existing tasks are modified or new tasks are required. The employer must keep up on the way that the work is being performed and provide additional training if needed. Training records must be maintained for 3 years from the date of the training occurring and include the following information. It must include dates of the training sessions, contents or summary of the training sessions, names, qualifications of the person who conducted the training, as well as names and job titles of all persons who attended the training. The elements of the training includes providing a copy of the standard, discussing modes of transmission, implementing a site-specific exposure control plan, discussing hazard recognition. How can we identify moments where we may be exposed to this hazard? Use of engineering controls work practices and PPE, as we've discussed, should be discussed during training. And the standard requires that a live question and answer session be provided for employees. So while OSHA does allow digital or distance training, employees must still have access to a live person to answer questions during that training. So the person does not necessarily need to be in the room, but they must be available via phone call. And this person must be, of course, adequately knowledgeable in the subject matter as it relates to the workplace. So the exposure control plan must be written and reviewed at least annually to reflect changes in any tasks, procedures, assignments which have affected exposure, and any technology that will eliminate or reduce exposure. So we're going to annually be considering what is available on the market, what potential engineering controls or work practice controls can we implement. Technology is rapidly evolving, and it is the employer's responsibility to keep up with that and see what's commercially available and can be implemented in our workplace. The standard requires that they must solicit input from potentially exposed employees in the identification, evaluation, and selection of engineering and work practice controls. We really want to see those who may potentially be exposed having the say that they deserve when discussing these serious matters. And of course, the plan must be accessible to employees. The exposure control plan will identify the jobs and the tasks where occupational exposure to blood or open may occur. And it will describe how the employer will use their engineering work practice controls, ensure the use of personal protective equipment, provide training, provide medical surveillance, the vaccinations, and use the signs and labels that we've discussed. So for some common OSHA violations that we've seen in medical settings, firstly, not using safer sharps for needles and scalpels where there is a commercially available safer medical device. We will still see sharps without any of those engineering controls being used. We'll see no exposure control plan or hazard communication program in place. Employees may not be offered the hepatitis B vaccine. They may not be providing the training required by the standards. Where there are corrosive chemicals used, we often see no eye wash station or goggles being used, or PPE may not be provided at all, or the employer may not be requiring it to be worn where it is necessary to protect the health of that employee. All right, so I hope that was some good information, some good reminders about bloodborne pathogens and the standard. We're going to talk a little bit about hazard communication and then wrap this up. So let's talk about hazard communication and how the standard applies. So it applies to any chemical present in the workplace and used by employees under normal conditions of use. Examples include cleaning and disinfecting products, ointments during wound care, preservatives used in tissue collection. These are things that we may see in your industry. Hazard communication does not apply to food, drugs, or cosmetics when packaged and sold to consumers for personal consumption. And it does not apply to consumer products that are used in a manner that is frequent and similar to how a consumer would use that. For example, if an employer is using Lysol wipes to clean the table in the break room, that would not fall. The hazard communication standard would not apply to that. All right. So the term globally harmonized system is one that you've probably heard before. So in 2016, the hazard communication standard was in 2016, the hazard communication standard using the globally harmonized system became effective. And so there are certain requirements that we have. Those include a written program, a chemical inventory list, safety data sheets, labeling of hazardous chemicals, and training. So we'll discuss those. So an overview of these changes when we went to the globally harmonized system. The definitions of hazards have changed, and they're now located in the appendices A and B of the standard. And this helps the manufacturers around the world, we're global with this, evaluate the hazardous effects of these chemicals. And we're looking at labels that are now standardized and how the information is provided, harmonized signal words, pictograms, and hazard statements. So we'll take a look at some examples. And as well as safety data sheets. So we're not calling them material safety data sheets. This was, back in 2016, but we still see material safety data sheets. We do not call them that anymore. They are safety data sheets. And each safety data sheet has 16 sections that are standardized. When we're talking about the hazards, we have 6 classes of hazards. Physical hazards, and that would include flammable liquid. Health hazards, for example, a chemical that is corrosive to the skin. We have simple asphyxiant hazards that deplete oxygen. We have combustible dust. We have pyrophoric gas hazards, those in which a chemical comes in contact with oxygen and ignites immediately. And then we have hazards that are not otherwise classified. So for the labels that are now standardized, we'll have a product identifier that you'll see on the safety data sheet. On the first page, we'll have the signal word, the hazard statement, and the pictograms, as well as precautionary statements and the contact information for that chemical manufacturer. So this is what it might look like old versus new before the globally harmonized system. On the left, we have different colors that denote different things. We have kind of a difficult, hard to read label there. And with the globally harmonized system, the pictograms are standardized. They will always look like that. And we can see we have that signal word of danger, warning, or danger, the product identifier. And yeah, this is another one. We can see those pictograms that always remain the same, the signal words, product identifier, those precautionary statements, extremely flammable gas, contains gas under pressure, and that information at the bottom there. These are our 9 pictograms. So in OSHA, we're not too concerned about the environment, but we'll take a look at all the other ones. And it's very important that when we're training our employees in hazard communication, they're able to look at one of these pictograms and say, okay, this is a corrosive chemical. This is just a closer look at that label. When we're looking at safety data sheets, they'll often have that CAS number. And we want to pay close attention to the language. Like I said, warning may be warning, it may be danger. We want to pay close attention to that language. Secondary containers must be labeled, and they must be labeled with a product identifier, and the product identifier that we see on the safety data sheet must be on that container. And it also must be labeled with words, pictures, symbols, or a combination that provides general information regarding the hazard. So if I have a secondary container of acetone, I'm going to write flammable and or include that flammable pictogram, as well as including that product identifier name. These are the different things that you might see on a secondary container, so long as it communicates the product identifier accurately and includes a descriptive word for the hazard or the pictogram. If the information is getting across, that's what's important here. But I like to re-emphasize that we need to have the exact product identifier on these secondary containers. Like I said, we're not going to say MSDS anymore. And the written or printed material concerning a hazardous chemical is prepared in accordance with paragraph G of the standard. So these chemical manufacturers have to keep in mind these requirements. And these safety data sheets now include 16 sections, must be in a specific order, must include specific information. If something were to ever happen in an accident, you need to grab a safety data sheet for a chemical, and you know that the information regarding first aid is in a specific section. You can open up right to that. So I hope I took up an appropriate amount of time there with our little overview of OSHA regulations that are applicable to you all and your medical professionals. Thank you for taking the time out of your leap day to listen to me talk about that. I am a compliance hygienist, but I'm happy to answer any questions if you want to reach out via email or anything. Sometimes it can be helpful in specific situations to have somebody to help you sort through those letters of interpretation and such. So yeah, thank you again. I'm gonna stop sharing my screen now and turn it back over to Susan.
Well, Erin, thank you so much. We really appreciate that level of detail. We needed to get into the weeds. It's all important. And so I want to open it up to all of our participants to see if you have any questions that you want to pose directly to Erin. You can just unmute and ask her if you'd like. Any questions?
Hi, Erin, and thank you for that presentation. So this is not, it's probably something different, but I wanted to confirm, are we required to submit data to the ITA this year? Is the state of Maryland Physicians Offices required to do so?
That is a good question. So they've changed things. You're asking about the electronic submission of the injury and illness logs, correct?
Yes, please. Thank you.
Yeah. So I am not too familiar with who has to submit electronically and who does not because some of these things are new, but I'm happy to get back to you with that answer for sure. If you, how should we do that, Susan?
I actually started emailing you and I thought, let me just ask.
Gotcha. Yeah. I'll respond with your
Sure.
email. Definitely. I'll find that out.
Okay. And I'll copy you, Susan.
Yes, that would be great because part of what we like to do is it's not just Priscilla who has this question, I'm sure, is that we like to follow up and put this in our e-news to clarify those kinds of questions for all of our practices. So if you would keep me in that loop, then we'll make sure to share it with others.
Okay, great. And
Yeah.
just to mention that this is due on the 2nd, which is this Saturday. So we have submitted ours, but I just wanted to make sure that we were required to, because the website does not really say if we're not required to.
Gotcha. Yeah, we can definitely get you that answer.
Thank you.
You're welcome.
So then at least if you can circle back with me quickly, then at least we can get it to everybody that was on this call so that they'll have that information and then also put it in our e-news. But of course, our e-news doesn't go out until Sunday, which is a day after the deadline, it appears. But yet I'm sure there may be a little grace in that regard. All right. Any other questions?
This is Ketlard. Erin, I would like to know if there is a standard form for new employee OSHA training. I'm trying to get some online, but they're not all the same. Do you have a standard form that we can use?
Standard form. So are you using the word standard to apply to the regulations, or are you talking about like a standard form, like physical form for?
Yes. Like when you have a new employee and you want to check, all the topics that you go over with them, like the blood-borne pathogen, the exposure and everything. So is there anything or anywhere I can go look for one?
Yeah. So in terms of keeping those training records, we do have some templates for that. So I'm happy to talk to, I'm gonna admit Cristina right now. I see her.
Right.
So we do have some templates that we're able to give to employers that provide a template for you to outline, those things that need to be in those training records. In terms of like actually providing the content of the training, I wouldn't have anything to give you there because it needs to be so work site specific.
Yeah, I understand that.
Right. Yeah. But if I'll talk to Cristina and I'm sure we can get those templates to you.
Thank you so
Again,
much.
if you want to send those to me, then we can forward them out to everyone.
Okay.
Be happy to do that. So
Thank
I
you.
think there was, of course. So I think there was another question.
Yeah, so this is a question about subletting. So I'm an employer and most of these talk about the employer's responsibility. I have space in which I'm subletting to another healthcare professional. And so my question is what is my responsibility from an OSHA standpoint to someone who is working in my space, but I don't employ them?
That's a great question. So it's pretty obvious that there are certain things that you wouldn't need to provide, such as training. But then when we're talking about things like laundry, I understand that it might get a little bit tricky there. Let me think for a moment.
If Cristina joined us, would that be something that she might also be able to address?
Yeah, Cristina, are you available?
Yes. Can you repeat the question for me?
Yeah, so I'll give you the specific example as well. So I have a medical practice. We follow OSHA guidelines and we have practices and training. We're doing this training. My employee is sitting here with me listening to your presentation. So thank you, Erin. I also sublet a room in my space, and the person who uses the room does IV therapy. Okay, so she's not my employee. She's just subletting the room. Now we do all the medical waste and sharps and stuff like that. So, and she uses that as part, so we have all that stuff. But since she's not my employee, I guess my question is, what is my responsibility from an OSHA standpoint since she's not my employee? Like I don't, I train my employee, but am I responsible for training her? I obviously we need to make sure, in other words, in the facility, like we have to have the labels are on the products, like anything that's in that space, I have to make sure as the space owner, I guess, to make sure that's in place. And that's fine. It's more the training and like, so for example, is it my responsibility as essentially the landlord, if you will, to make sure that this person who I sublet has her Hep B vaccine? And do I have to keep record of that? She's not my employee, but she's in my space. So am I responsible for everything, or is there a way to define space versus person?
So the definition of employee as far as OSHA is concerned comes down to control, who's controlling the hours, who's controlling the work, who's providing the materials. And so in this instance, I would ask, this person might be, let's say, what the IRS might call an independent contractor. But if you are setting the hours and saying, I need you to be here X, Y, Z, if you're providing the supplies, like the IV therapy and the needles and the tubing and everything that goes with that, if you are establishing, if you would discipline this person, like if you were to say, well, you didn't come in on time, so I'm going to suspend you or reprimand you or something. That's how you kind of define whether or not this person is a quote unquote employee of yours, and then that speaks to the level of responsibility.
Right. So in this case, so that none of those apply. So in other words, I don't do the supplies, I don't do the discipline. She has access to the room whenever she wants. I'm literally providing her a room. So, I mean, I've also, because we have a shared facility, she has access to, for example, where contaminant waste goes. So I take care of that for her. And she has access. I mean, I think she has her own sharps box, but no, she does the needles. We take care of that. We take care of the contamination. We have a cleaning service that cleans the room, but other than taking care of the room, I don't really do anything. She doesn't report to me. I don't employ her. I don't set her hours. She's not an employee by any sort of standard. And so while we maintain, I make sure that the space has the waste control, the sharps control, stuff like that. And we have a cleaning service to clean the room. I'm not training her on how to, and documenting her training. I'm not checking her Hep B status. To me, that would be something her employer, because she has an employer, her employer would do. I just want to make sure that I'm doing this right, that I don't have any responsibility other than the space aspect, because it's my space.
I agree with you on all fronts here.
Okay.
It sounds like this truly is a situation where she and or her employer are responsible for, all of the elements of the safety and health program as it relates to exposure to bloodborne pathogens.
Great. And do I have any responsibility as a landlord or a renter to make sure that her employer is compliant?
No.
Okay. Thank you. That's very helpful.
Okay, good.
Are there any other questions?
I
Well,
just
go ahead.
I would like to know if we can get copy of the presentations email.
Yes, you can. And actually, we also have been recording this. And so for all of you, you will have access to this recording in the future. So that should be helpful to you as well. But yes, we can send out those slides.
Thank you.
All right. Well, certainly Erin and Cristina are available after this presentation to answer any additional questions that you may have. We appreciate that you raised those, some of them being very specific to your own situation. And so I'm sure they're available to you to consult and to offer you advice and counsel about your own particular situations. So we thank Erin and Cristina for joining us today. Very pleased that we're able to provide this value to our practices. We thank you for doing that. And what I would like to do now, if you'll just stick with us for just a few more moments, is to talk with you about compliance. To your point, Ketlord, you brought up the fact that, are there sheets? Are there ways to document that your employees have had this training? And so I would like to speak with you just a moment. I believe Jack has rejoined. As we noted at the beginning of the presentation, Jack DeJoya has a platform that allows and assists and supports a practice's compliance efforts. And so it is something that it includes OSHA, it includes HIPAA, it includes bloodborne pathogens, and it includes fire safety, which I gather from a recent survey that not many individuals are doing, even though that was something that was touched on today by our speakers in terms of exit routes, that sort of thing. It does not at present include active shooter, but that is something that we could look into. So I would just appreciate some comments, if you don't mind, about number one, are you doing this internally now? Are you using an external vendor to help you comply with these regulations? And would potentially a platform that has these different pieces all centralized in one platform that could do training, documentation, policy development, would that be helpful to you? So I would just appreciate anyone that would be willing to speak up about those two things. Their platform is continually updated, and we want to make sure that we are pushing out the best and most updated information to our practices on these topics. So would you mind sharing kind of what your practice is doing now? Are you doing this all internally? Are you using a vendor? Okay, I appreciate Priscilla responding to that in chat. Chat is fine if you want to share what you're doing. Anybody want to just share verbally what your practice is doing? And then also, if you don't mind putting in chat just whether or not you see a value for the medical society and for this company to be pushing out this platform that would help you to organize these compliance efforts. Okay, we appreciate that feedback. Any other comments? Well, obviously, you wouldn't be here today if you were not concerned and committed to compliance in these areas. This is something the Medical Society has been involved in for probably 20 plus years. And we're just looking at the different solutions of how we can continue to serve these efforts, but making sure that you have the most up-to-date information possible. We certainly don't want to be pushing out any information that is not as updated as possible. We did send out a survey about this some time ago to all members. We did only get 5 responses. We still would welcome responses to that survey. And so I think what we might do is to forward you that link and just see if we can also get some additional feedback that way.
And Susan, if I could throw out,
Yes,
if
please.
anyone is interested in it, because I just kept hearing it come up multiple times in the conversation, the SDS sheets, where am I logging my trainings? And this place is this online training program is like a one-stop shop for that. So I'd love to offer up if anyone wants to take a look at it, 10 minutes, we can share a screen, we can demo it for you. It's nothing robust. I'm sure it's similar to what you may be currently using. We actually just had one with a current customer of ours who was saying that it looks exactly the same as one of their other programs they were using, but This one's just at a lower cost. So I'd be more than happy to show you guys what it looks like and kind of walk you through it with a quick demo.
Yeah.
But yeah,
Thank
just
you,
want to throw
Jack.
that out there.
All right. So on that note, the only other thing is, do you have any questions at all about anything that's going on in the medical society? Any services or other value that you would like to see us consider offering? We welcome that kind of feedback always. Well, we thank you very much for spending part of your LEAP day with us and learning more about OSHA compliance. We thank our speakers again. We really appreciate the collaboration of our MOSH speakers. We will offer again this sometime in the fall. So if you have additional employees or you want to see what might be new by the fall, we would encourage you to join us then as well. So thank you very much. We hope you have a great rest of your day and your week. Thank you very much.